Hi, this is Alan, and we're going to be talking about lung inflation therapy today. One of the things that we're doing with lung inflation therapy is that we have four basic modalities for lung inflation therapy. One, just getting the patient to deep breathe on their own, getting them up out of bed, having them deep breathing, be able to possibly cough up any kind of secretions and reinflate those alveoli. If the patient's not doing that effectively, then we're going to go to something that might give them some incentive, which is incentive spirometry. And that's a deep breathing exercise too, but it actually gives a visual goal for the patient to hit. If the patient's unable to do that or not cooperating in doing that therapy for you, then the next option will be IPPB, intermittent positive pressure breathing. It's been a therapy that's been around for a very long time, and it's a therapy that some therapists really understand, and other therapists, they just hate it. It does require you to think about what you're doing. Every knob on the machine will affect the way you deliver the breath to the patient and how well the patient will be able to take that deep breath in. And so you're going to be manipulating your inspiratory time, you're going to be manipulating the flow and the pressure and the sensitivity level, pardon me. And that's all going to affect the patient's tidal volume, or how large the volume of air that goes into the patient. And because it's a little complicated and it's not just setting a knob, you really have to think about that. I think that some of the therapists just aren't feeling very comfortable or confident with their ability to use that pressure ventilator. But if you don't have that available, another option which has been backed by the AARC, and that is EzPAP. And EzPAP is a lung inflation therapy that uses positive pressure going into the airway. Patient's just going to put a mouthpiece in their mouth, they're going to bite down, tight seal, and they're going to diaphragmatically breathe. Diaphragmatically breathing means you're belly breathing. Right now I'm going to demonstrate how you take a deep breath in normally. Okay? Well, if you're going to take a deep breath in normally for me, I'm going to breathe in, and you're seeing my shoulders raise and my chest come out. Because you're seeing my shoulders raised and my chest coming out, that's chest breathing. Belly breathing, or diaphragmatically breathing, is that you're breathing from your belly and not using your chest. So when I instruct patients, I ask them to put their left hand on their chest and their right hand on their belly, and to breathe normally. And then what I'll want them to do is to go ahead and take a slow, deep breath. Well, if I see that, I know that they're a chest breather. If I see them do this, you can see that my belly was coming out. That's diaphragmatically breathing. For this therapy to be completely effective, we want the patient to diaphragmatically breathe, and that's from the belly. So you're going to have to possibly coach the patient on how to breathe from their belly if they're a chest breather. If they're already a belly breather, it's not going to be a big deal. Okay? Again, for you, put your left hand on your chest, your right hand on your belly, take a deep, or just breathe normally, and then take a slow, deep breath to find out which kind of a breather you are. That would be a chest breather. This one would be a belly breather. You notice that my shoulders and my chest didn't move, it was just my belly. Once we're able to get the patient to do that effectively, we want them to do their normal breathing, anywhere from 12 to 20 breaths per minute, and this therapy can last for about 10 minutes. You can also give this EzPAP therapy with your bronchodilator. You would actually take your small volume nebulizer, put it in line, run your nebulizer at the normal flow rate, 6 to 8 liters per minute, and then you would set your flow meter for your EzPAP starting at 5, and slowly work your way up as necessary. Well, that would be a therapy if the patient can follow the commands. Both the IPPB and the EzPAP can also be done with a mask. Same kind of mask that you would use for an ambu bag. If that doesn't, you have another alternative, is your PAP therapies, which is your positive expiratory pressure therapies, your EPAP, end expiratory positive airway pressure. CPAP, continuous positive airway pressure, and BiPAP, bi-level pressures of positive airway pressure. And, pardon me? What you need to do is, to, okay, where did I leave off? BiPAP, bi-level PAP, so bi-level of positive airway pressure. You're having a high pressure and a low pressure, okay, that you're adding to the airway. And because we're using 2 levels of pressure, the reason we're doing that is if we're at a high level of pressure, say 15 centimeters of water pressure, the patient has to breathe in with that and breathe out against that. And that can also increase the work of breathing. So what we do is we give a high pressure for inspiratory, and then when the patient's ready to exhale, we lower the pressure down to a lower pressure so it's easier for the patient to exhale. So they don't have to breathe as hard against that positive airway pressure. We don't let it completely go back down to 0, but we bring it down from 15, say, down to 5 or 8, making it easier for the patient to exhale. Okay? Well, those are your lung inflation therapies that we were talking about. And today we're looking at EzPAP. And what we would do with EzPAP is the first thing we would do if we had a requisition for lung inflation therapy is to follow your hospital protocol, do an IPPB, grab an IPPB machine. If it's an EzPAP, grab the EzPAP. They're both recognized as lung inflation. I'm going to grab that, then I'm going to go to the patient's floor. I'm going to go find the patient's chart, and I'm going to check for the patient's name and ID. I'm going to look for the physician's order. I'm going to look for indications as to why am I doing this lung inflation therapy, and find that probably if there's a recent chest x-ray. Look at the nurses and physicians' notes to see what they had said about breath sounds. There might be something in there that indicates the patient already has a pneumonia. They might have a white blood cell count that's elevated. Something that tells me why this therapy is needed. That's what I'm looking for on the chart. And I've already checked the patient's ID to make sure that I have the right patient, I'm doing the right treatment for the right reason. After I've done that, I'm going to gather my equipment. I'm going to get my stethoscope, my watch. I'm going to grab the EzPAP, flow meters, pulse oximeter. I'm going to grab all the equipment that I need, and then I'm going to proceed to the patient's room. When I get to the patient's room, I'm going to be right here. Derek is going to be my patient for today. And when I get to the patient's room, I'm going to introduce myself. My name is Alan. I'm from Respiratory. And your doctor has ordered some lung inflation therapy for you. Okay? And at that point, I would go over to the sink and I would wash my hands, making sure I got them really clean. Okay? Remember 15 seconds, sing one stanza of Happy Birthday. Then I would dry my hands. Okay? After I've done that, what I would do next is go over to my patient, check their patient ID to make sure they are who they say they are, and who this order is for. And then I would explain to her, Ms. Derica, your doctor, like I said before, has ordered this lung inflation therapy, and this one is called an EzPAP. Have you ever had an EzPAP treatment before? No. Okay. All this is a deep breathing exercise. And what we're going to have to do is we're going to have to get you to deep breathe for me during the therapy, but this might be a little different from you. We're going to need you to belly breathe. It's also called diaphragmatic breathing. I don't know if you've ever taken a yoga class or something, because at the very beginning of a yoga class, a lot of times the instructor will have you deep breathe and cleanse your body of all the negative stress and vibes that are going on, and they want you to diaphragmatically breathe. And we need to find out what kind of a breather you are. You might be a chest breather or a belly breather. And the way we need to do that, if you'll follow my instructions, is we're going to put your left hand on your chest and your right hand on your belly. And I'm just going to ask you just to breathe normally. Now I want you to take a slow, deep breath on the next one. Deep breath in. Deep, 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 deep. Out. Deep, 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 deep again. Okay. I'm seeing your chest rise. At the very beginning, I thought I saw some abdominal breathing, but then when I asked her to take a deep breath, it was all chest. what I want you to do, Miss Derrick, is to not let your chest or shoulders rise, and just let your belly come out, like this. Good. I'm seeing you exactly, so you know how to do the exercise. What I'm going to ask you to do is we're going to put this device together, and you're going to put it in your mouth, you're going to bite down, and you're going to breathe just like you're doing when I said take this slow, deep breaths. You don't have to keep your hands on your chest or belly now. Slow, deep breathe just like you just did. It's not a race. You don't have to go really super fast, and we're only doing the EzPAP treatment this time. The next time you're going to be due for your medication, your bronchodilator therapy, and we'll do the two of them together, so we won't have to do them separate. But you get this treatment more often than you get the bronchodilator small volume nebulizer. But if at any time you start feeling lightheaded or dizzy, or you feel anything is out of the ordinary, or you start feeling some pain, I want you to tell me and we can stop. Okay, I see that you have a family member or a friend here. Is it all right if they stay here during the therapy? Yeah. Okay. Do you understand everything that I'm looking for you to do? You understand? Any questions? You have questions?
Yeah, when I take the treatment, am I diaphragmatically breathing?
Yeah.
Okay.
I'm going to coach you along the way, so you don't have to worry. My job is to stay here with you and to watch you during the therapy. Okay? And right now I told you that I think you're a belly breather, like when you're just relaxed, but when you take a deep breath, you're using your chest muscles. Okay? Your family member, is your friend or family? Friend. You have any questions? No? Okay, great. Okay, well the first thing I'm going to do is I'm going to check the patient's heart rate, respiratory rate, sat, color, and level of dyspnea, shortness of breath. I would check breath sounds, 4 in the front, 6 in the back. And at this therapy, okay, we might want to have some mechanism, some way of being able to check the patient's deep breathing ability. So I might want to check a vital capacity, an inspiratory capacity, or maximal inspiratory pressure. Something to gauge before the therapy how well the patient was doing, and something to gauge if the patient got better afterwards. Inspiratory capacity is good, vital capacity, maximal inspiratory pressure. Those are good indicators. They're getting better. Patient's doing better. But, you know, for this purposes right now, for our checkoff and for you guys, we're not going to do that. If I was doing the bronchodilator with therapy, I would go ahead and do the peak flow, because it would be indicated. I want to see if the patient had more airflow going through their lungs. And I would hope that the bronchodilator relaxed the smooth muscle and allowed the patient to take a deeper breath, and that means the patient should be able to exhale more with the peak flow. But since we're not doing the bronchodilator now, we're not going to do the peak flow. So now what I'm going to do is, after I've done my assessment, I'm going to go ahead and put together all the equipment. The devices that I have purchased for our students, we have purchased or require the students to purchase here. This one comes with a pressure manometer, okay? This one comes with a pressure manometer. You can buy these setups without the pressure manometer, but right here is where you would hook up the pressure manometer. Now, if you remember, we could use just some oxygen tubing and connect that to an external or a handheld pressure manometer, and we could find out what pressure the patient is, what pressure we're getting at to, the peak inspiratory pressure. Here is where we're going to hook up our oxygen. So we get our oxygen tubing. We can hook it up to either air or oxygen. We'll hook it up to oxygen here. And I can hear that my oxygen, I have airflow. And what I'm going to do is I'm going to hook up my oxygen tubing, okay? And then I have my bag, and I'm going to go ahead I'm checking, and I can see that my device is working. Okay, I'm including with the bag. I'm going to turn this off. Grab another paper towel. And And what I'm going to do is I'm going to hand this to the patient. Okay? Let's get that a little straighter. Okay. What I want you to do, Miss Erica, is I'm going to put that in your mouth. And I want you to bite down tight. Keep your tongue out of the way. And that diaphragmatic, the belly breathing, I want you to do that. Okay? And I'm going to slowly start increasing the flow rate. Okay? So you just breathe normally for me. We're going to start at 5 liters per minute. Okay. Just slow down, just relax, it's good. You doing all right? Now I can look here and I can see, if you get closer, you can see where the pressure manometer, the red thing, the red indicator, is going up to almost 10, but she's still coming all the way down to 0. So I'm going to increase this a little bit more. Okay, we're looking at about 15 right now. Make sure you're breathing from your belly, okay? You doing all right? Okay, slow down your breathing. Okay, remember, try to breathe from your belly, not from your chest. Okay, very good. Okay. Now you would continue to do this, you know, for as long as the nebulizer treatment was going. And what I would do here is where the mouthpiece and this part here are connected, I would separate that. Take that out of your mouth. You can separate this right there, and you would put the nebulizer treatment in the pipe, instead of hooking up the mouthpiece and the blue corrugated tubing, the reservoir end, I just put that T-bar in between, or that Briggs adapter, hook that between, and the nebulizer would sit right in the front here with the EzPAP. And you'd run that nebulizer at 6 to 8 liters per minute according to manufacturer's instructions. I'll let you hold that. You don't really have to go through a lot of cleaning. If you get some things on the mouthpiece, you could rinse that off with warm water and soap and clean it off and then let it air dry. But this is really something that you're not going to have to wash the internal parts. I guess if you used a medication nebulizer, you'd want to make sure that you air dried it well. But for this, just making sure that it stays clean, you put it back into a treatment bag, and it's prepared for the patient for the next time that they come, that you have to do the therapy. At this point, I would ask the patient, can you do me a favor and take a deep breath, deep, 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 and cough hard. Okay, good. At this point, I'd ask her, I don't see anything. Have you coughed up anything prior to me coming?
No.
No? Okay. Well, at this point, I would check her vital signs again, heart rate, respiratory rate, sat, color level, dyspnea. And then I would do her breath sounds, 4 in the front, 4 on the back, 2 on the sides, making sure she was breathing appropriately through her mouth for the breath sounds. At this time, I'd ask Ms. Derica if she had any questions.
No.
Okay. If I did a peak flow before, I'd want to do a peak flow after if I gave a bronchodilator treatment. If not, then I might want to check the inspiratory capacity, vital capacity, or the maximal inspiratory pressure, which my students are not going to be responsible for right now, but later on when your respiratory practice, we will learn how to do those procedures. Now, do you have any questions for me?
No.
No? Okay. Well, your therapy is ordered for every 4 hours. And so we'll be back in about 4.5 hours to do your next treatment. And do you have any questions for me? No? Okay, good. And family members, do you have any questions? No? Okay, great. I know I've repeated that a couple of times. It's really important to make sure the patient participates in the care. It's very, very important that they give you feedback and they know what they do, that you need them to do. More than likely, if you've had somebody who's alert and cooperative like I've had with Ms. Derica today, she might have already had an incentive spirometer that she wasn't capable of doing before, and now we've moved up and progressed to the EzPAP. This is not a bad time to just tell her, while you're gone, she can take that incentive spirometer and she can practice doing that 10 times an hour. Okay, you remember this device? Okay, I need you to deep breathe. Try to do that 10 times an hour. The quicker we can get you feeling better, the quicker you're going to be able to go home. And that's what you want to do, right?
Yes.
I know. Okay, great. I will go to the sink now and I wash my hands. I would tell the patient, we'll see you in about 4.5 hours, and then I would proceed to the patient's chart, and I would chart the therapy, and that would be what was the highest pressure that I measured on the pressure manometer, what was the flow that I have set on the flow meter, what was the patient's pre and post vital signs, breath sounds, and whatever kind of lung measurements that I had done. If I had done breathing treatment, I'd also put the treatment down that I had done. And I would date it, the time, and it was a respiratory note and treatment given. And at the very end of my charting, I would say that the patient tolerated the treatment well, if they did, and that there were no adverse reactions, if there weren't. If there were, I would document those things and what I did. Then I'd sign my name and my credentials. Again, this is Alan talking about lung inflation therapy. Hopefully this has been helpful, and I will see you next time.